Okay, here we are at the second part of the Disorders of the Nervous System chapter, and we're going to go ahead and get right into the next problem we see with nervous system disorders, and that's a brain tumor. Brain tumors may start as a primary cancer, or they may be the result of a secondary cancer that began somewhere else in the body and metastasized to the brain. They can be benign or they can be malignant, and certainly if they're benign, then once removed they don't pose any additional problems. However, if they're malignant, then they are often terminal. The problem with brain tumors is, of course, you have the mass effect. And with mass effect, as the tumor grows, it compresses the brain tissue and also causes intracranial pressure to rise. Both of those things, of course, cause dysfunction with the brain. And if the tumor is malignant and gets large enough, it'll actually cause herniation syndrome, compression on the brain stem, and eventual loss of all vital functions. So when somebody has a brain tumor, the therapeutic interventions would be to obtain a primary survey. They're going to present like any stroke patient or any patient with a brain abscess, where there might be some neurologic deficits, some facial droop, slurred speech, numbness, tingling, paralysis, particularly on one side of the body. But in doing your assessment, try to determine if they have any history, of course, in your sample history. When you get to the pertinent past medical history, if they've got any history of brain tumor. And if they are already diagnosed with brain tumor, then try to determine their DNR status, because obviously if they're calling you, you know, they may be pretty sick. In fact, seizures are common with brain tumors as well. So if they are a DNR person, have a DNR order, if they do have a DNR order, then you would consider supportive care. Patient and family education that should occur, you know, from the physician, if not already done. Certainly encourage them to call 911 if the patient experiences any unexplained or persistent vomiting, any double vision, blurred vision, increased sleepiness, seizures, headaches of a different type than usual. All these certainly would indicate an increase in the mass or the size of the tumor. A brain abscess could be a collection of pus in the brain itself. And, you know, if you think about the skull, it's an inflexible box that does not give in the adult patient. It has one natural opening in the base of it called the foramen magnum, and essentially is occupied about 6% of your skull is occupied by your brain, your meninges, your vessels, and your cerebral spinal fluid. So there just really isn't any space for any additional swelling. Pus is certainly somewhat liquid, and because it is a liquid, it's not compressible. So as the pus continues to collect, you get a mass effect, much like you do with a brain tumor or a brain bleed. And it's going to cause some sort of neurologic dysfunction, some sort of stroke-like presentation. The etiology of brain abscesses certainly can come from penetrating head injuries, neurosurgery, or what's interesting with brain abscesses is that if a person has had an infection of the sinuses per se, that can actually get into the brain and cause a brain abscess. So an infection of any nearby structure could also, weeks later, lead to some sort of brain abscess. Your history and physical findings, because of the mass effect, are going to have a headache, altered mental status, focal neurologic deficits, in other words, on one side of the body, They may have a fever, seizures, nausea, vomiting. Certainly if the meninges are inflamed, nuchal rigidity or the inability to touch their neck to their chin. Some differential diagnosis that come into mind when you're thinking about brain abscess. It's going to look a lot like meningitis, encephalitis, a stroke, or brain tumor. And therapeutic interventions include supportive care on our part and getting him to a neurosurgeon so the abscess can be evacuated. Cerebrovascular accidents or strokes is a sudden change in the neurologic function caused by an alteration of cerebral blood flow. And that sudden change in neurologic function could be the result of either a thrombus, an embolus, or a hemorrhage or a brain bleed. In any event, it's going to lead to troubles. Patients may have trouble seeing, they may have trouble swallowing, they may have trouble speaking, they may have trouble walking, numbness, tingling, paralysis, particularly on one side of the body, facial droop, arm drift, slurred speech. All those things we've been taught to look for may be present with a cerebrovascular accident. When we think about the blood flow of the brain, it's quite significant. The brain requires a constant blood flow, and it's got several circuits. It's got central blood flow through the anterior circulation, which originates in the carotid arteries, and it supplies the frontal, the anterior parietal, the anterior temporal lobes, and the posterior circulation originates in the vertebral arteries, and it supplies the brainstem, the cerebellum, and the posterior parts of the cerebrum. And the circle of Willis allows a continuation of perfusion if the anterior or posterior circulation is blocked. So if one of those main arteries coming up to the brain, either of the carotids or the vertebrals, become occluded as a result of a clot, the circle of Willis will allow for continued perfusion to the brain tissue itself. Now, 80% of all strokes are ischemic, and what that means is that blood flow in an artery has been blocked. It can either be blocked by a thrombus, which is a blood clot that develops at the site, or an embolus, which is a blood clot that travels to the site. And typically a thrombus, the symptoms will be gradual, where an embolus, the symptoms will be sudden. Emboli, typically for head, come from either the aorta or the carotids. Either the atrium, like in the case of atrial fib, or from the carotid arteries. So ischemic strokes are the result of atherosclerotic plaques that form in the cerebral vessels, and clots break free from those plaques when they rupture and get lodged in other vessels in the brain, causing a stroke. So an ischemic stroke is actually included in the discussion with cardiovascular disease because it's caused by the same thing that causes heart attacks. Now, a lacunar stroke is a stroke that's deep in the portions of the brain, and it affects the thalamus, the hypothalamus, the basal ganglia, the pons, and that's when the deep vessels, not the vessels on the outside of the brain, the large vessels, the anterior and posterior circulation, the circle of Willis, those are all on the outside. Those can rupture or become occluded, causing an ischemic. If they become occluded, can cause an ischemic stroke. But a lacunar stroke accounts for about 20% of all ischemic stroke. The patient's going to present with classic stroke symptoms depending upon what part of the brain is not receiving a blood supply, and these would be very deep vessels within the brain tissue itself that have become occluded from either an embolus or a thrombus. Embolic strokes, as I had already mentioned, can be caused by atrial fibrillation, can be caused by mural thrombus that form on the walls of the carotid arteries or in the heart. Another type of stroke is hemorrhagic, and hemorrhagic strokes occur when a blood vessel in the brain ruptures. leading to intracerebral hemorrhage. Certainly could be subarachnoid hemorrhage, could be epidural hemorrhage, subdural hemorrhage, and most often hemorrhagic stroke is caused by hypertension. Can also be caused by arteriovenous malformations and existing aneurysms that rupture when the blood pressure goes up. Sometimes they may not have an aneurysm, but if the blood pressure gets high enough, it may cause a vessel to rupture. They may have aneurysms that don't leak or rupture until the blood pressure actually goes up. So hemorrhagic strokes, regardless, are the worst of strokes, but they only make up 20% of all strokes. Now, when you're dealing with an ischemic stroke, you have an area of primary injury, and that area of primary injury is known as the ischemic penumbra. And that's kind of the core. That's like ground zero. That's where the artery is occluded, where the vessel has ruptured. That area is beginning to die. It's very unstable, and if we can restore blood supply to that penumbra, then the brain cells don't die. And this requires the administration of a fibrinolytic for non-hemorrhagic stroke within a very narrow window of opportunity. The window of treatment for ischemic stroke, if the candidate meets the criteria, is typically 3 hours from onset of symptoms. Now, most people are going to wait somewhere between 1.5 and 2 hours before they seek any treatment, so they chew up such a big part of that window that often by the time they get to us, there's not much that we can do for them. But should they recognize early that they are in fact having a stroke, and they are a candidate, and through a head CT it's determined that they do not have a bleed inside their head, they may be a candidate for a clot buster that would open that vessel up and supply blood to that penumbra and prevent that infarct from extending, making the brain injury worse. Now, in the pre-hospital environment, as far as assessment for stroke, we've all been taught the FAST-G, or the Cincinnati Pre-Hospital Stroke Scale. There's 5 or 6 different stroke scales out there. The Los Angeles Stroke Scale is another one that some folks like to use because it takes into account age, takes into account the presence of seizures, takes into account getting a blood glucose. But most of us are familiar with the FAST-G, where F stands for facial droop. Have them give you a big smile, and if one side of their face droops the scoop. About 72% chance they're having a stroke. If that isn't present, then we look at the A, which stands for arm drift. With their palms upward, have them extend their arms out, palms up, for a full 10-second count with their eyes closed. Now we have them close their eyes because if their eyes are open, they may favor one arm over the other. But if we have them close their eyes, hold their arms palm up for a full 10 seconds, if the arm turns over, stays up there, but just turns over, the palm turns down, that's called pronator drift, and that in fact is evidence of weakness on that side of the body, which would indicate a 72% chance of stroke. Or if the arm is unable to be picked up, or if the arm drifts away because of weakness on that side, then that would be evidence, a 72% chance that they're having a stroke. If that's not present, then we look at speech. The S stands for speech. We look at slurred speech. Slurred's a word. Have them say something that they normally don't say, like the sky is blue in Council Bluffs, or baseball player, or you can't teach an old dog new tricks, and see whether or not it comes out slurred. The reason we have them say something they normally don't say is that if you ask them to say their name, or if you ask them to say what month it is, or where are you at, if those are things they say frequently, even though the muscles in their mouth may be weak, they still may be able to get those common words out. But if you have them say something that isn't convicted to muscle memory, where they have to use different muscles to form those words, you can pick out much easier slurred speech. And if they don't have slurred speech, they don't have arm drift, and they don't have facial droop, then we really need to look at some of the other mimickers for stroke. If they do have facial drift, arm drift, or slurred speech, then the T stands for time, and we want to get a good idea of when the symptoms started. If they went to bed that night fine and woke up the next morning with stroke-like symptoms, they're automatically excluded from receiving the fibrinolytic, because we don't know if the stroke occurred 5 minutes before they went to bed or 5 minutes before they wake up. So time is important, and we have that 3-hour window of opportunity for most stroke patients. Now, those people under the age of 70, those patients who are not diabetic, who are not hypertensive, are not taking any meds for diabetes or hypertension, and who aren't taking warfarin or aspirin or those sort of things, they've extended that window of opportunity to 4.5 hours for that group. And then G is glucose. Something we could do easily at the bedside is get a glucose. Any patient with altered mental status, we should get a blood glucose, because that may be the cause of their altered mental status. So fast G is something we can do extremely quick, and with about a 72 to 85% accuracy, predict the likelihood that they're having a stroke. What we can't do with the fast G is predict the severity. That's done with the National Institute of Health Stroke Scale, the NIHSS Stroke Scale, which is what some of the physicians would do in the emergency department. But should we do the fast G, we would be able to tell within a matter of seconds whether or not it's probable our patient has a stroke. We could call a stroke alert, get the patient moving as quickly as possible towards that head CT machine, so that we could make certain that they're not bleeding inside their head. And if they're not bleeding and they're a candidate, administer them a clot buster and improve their neurologic outcome. When we load them into the truck and head en route to the hospital, one other thing that certainly is being advocated with EMS providers is a MEND exam, and that's the Miami Emergency Neurologic Diagnostic Exam. And essentially it looks at 4 other things that the FAST does not look at. The one disadvantage of the FAST is that it doesn't look at frontal lobe strokes, it doesn't look at cerebellar strokes, it doesn't look at brainstem strokes to any real degree. Essentially, the FAST G looks at hemispheric strokes, either left or right hemisphere strokes, which only account about 60% of all strokes. But by doing the MEND exam, and this is something we could do en route, we don't have to sit on scene and do it, we're able to pick up the presence of uncoordination or not being able to follow certain commands, which would indicate, perhaps a cerebellar or basilar or brainstem stroke. We're able to rule out the difference between dysarthria, which is difficulty speaking, and aphasia, which is no speaking at all or speaking the wrong words. Because those are 2 different types of speech patterns you'll get with strokes. Certainly with dysarthria, I may have difficulty getting the word out, and it may come out slurred, but it's the right word or the right answer to your question, but slurred. Whereas if I have aphasia, I can't talk at all, or when I do talk, I don't even use the right words to answer your question. And what's interesting about that is when a person has aphasia, they think they're saying the right word when in fact they aren't. And so they get really frustrated with you because they can't understand why you don't understand what they're saying. Because, you know, you could be looking at a cup of coffee and they could be calling it a cat. And you're like, coffee? And they're like, cat. And they just, you know, really get upset that you don't understand what they're saying. So the MEND exam is something that you can practice in your labs when you have a lab on a Thursday. There's a form that you can download off the internet and on the MEND exam that goes through the different steps of that exam, looking for, again, frontal lobe strokes, cerebellar strokes, and brainstem strokes. Some of your history and physical findings would include, of course, when you obtain your vital signs, it's not uncommon that in a patient having a stroke, particularly a hemorrhagic stroke, you're going to see a really high blood pressure and perhaps a slow pulse. The brain has the ability to selectively vasoconstrict vessels in order to improve cerebral perfusion pressure, or the blood pressure to the brain. And cerebral perfusion pressure can be defined by taking the mean arterial pressure, the average pressure in the arteries all the time, minus any intracranial pressure. Now, intracranial pressure is something that we all have inside our head. It ranges around 5 or 7 millimeters of mercury, and you can see whatever the average pressure in your arteries is, that you have to subtract from that ICP to get your blood pressure to the brain. So as ICP rises, the brain has to selectively vasoconstrict vessels in order to get the average pressure in the arteries to rise. Otherwise, it gets no blood supply at all. And MAP can be determined by taking the diastolic pressure plus 1/3 of the pulse pressure. And the pulse pressure is the systolic minus the diastolic. You could do a little, certainly an exercise if you took a person with a blood pressure at the arm of 120/80. We could determine that their MAP is about 72, and if we take normal ICP 7 away from 72, our MAP is 65. And you need a MAP of at least 60 to perfuse your brain. So let's go back to that very same blood pressure of 120/80. But for sake of argument, let's say that because of swelling inside our head from hemorrhage or a blood clot, our ICP is now 40. You take that same 72 minus 40, and you're left with 32. So even though the blood pressure at the arm is 120/80, which in no way is a shocky blood pressure, our MAP to the brain, because of a rise in ICP, is only 42. And that means the brain is not being perfused at all. So some differential diagnosis that you might think about when somebody has a stroke is certainly a head injury, and in my opinion a stroke is a head injury, a transient ischemic attack, a TIA, and we'll talk a bit about that here in the next slide, I think, meningitis, encephalitis, hypertensive encephalopathy. When a person's blood pressure is really, really high, it actually causes the ICP to rise, which decreases the cerebral perfusion pressure, and the brain doesn't get perfused well, and so they have classic signs and symptoms of stroke, but when you lower the blood pressure, the signs and symptoms go away. Could be an intracranial mass like a brain abscess or a tumor. Could be spinal cord or peripheral nerve disease. Could be seizures. Could be infections, complex migraines, Bell's palsy. Bell's palsy is a inflammation of the facial nerve. The facial nerve goes through a hole in the bone in your cheek or your mandible, and there are times when that nerve can become infected and swell, and there's no room for it to swell inside that where it passes through that bone, and as a result, when it swells, it paralyzes the nerve, so it paralyzes the face, and it certainly can mimic a stroke, particularly with facial droop. Guillain-Barré syndrome is a neuromuscular wasting disease, so in the later stages of Guillain-Barré, it certainly can look like a stroke. Hypoglycemia, that's why we get a blood glucose on the fast G, and of course drug or alcohol intoxication. Treating strokes, we need to call a stroke alert as soon as possible, and that allows the receiving facility to if they got to call somebody in to run the CT scanner, then then that's already happening. If we wait to call them when we're on the road or wait to call them when we're 5 minutes out, that may not give them the time they need to get prepared to have that CT scan fired up and ready to go. It also gives them an opportunity that if their CT scanner is not functioning, which does happen sometime, that they could direct or tell you where the next closest facility is that has a CT scanner that would be able to see this patient. You can do your focused exam en route. You can, if there's not a need to open the airway, ventilate, suction, that sort of stuff on scene, you can do your cardiac monitor, your oxygen administration, your IV access. You can do all that stuff en route. And you want to take them, of course, if you believe that they're having a stroke, to a stroke-capable hospital, which the vast majority of all hospitals in Iowa are stroke-capable. And eventually they're going to end up in a stroke center, one of the larger centers that that cares for patients with stroke. Now, a TIA, we had mentioned that a little earlier. A TIA is a transient ischemic attack, often called a mini stroke or a little stroke. And a TIA is a stroke that reverses itself. So it's a sudden onset of stroke-like symptoms that resolves in the first 24 hours, according to the World Health Organization, or stroke-like symptoms that resolve in the first 24 minutes, which is an American Heart Association definition of a TIA. It could be from a partial blockage, it could be from vasospasm, but the most important thing about a TIA is that the vast majority of people who have TIAs, if they don't make some serious lifestyle changes, then within the first 6 months following a TIA, 50% of those people have massive strokes. So you can see that TIA is a warning sign. As far as the history and physical findings, people who have TIAs have them often. So they may have a history of mini strokes. They may have a history of atrial fibrillation or other cardiac dysrhythmias. TIAs can be the result of excessive stimulant use, like nicotine, caffeine, and certainly sympathomimetics like cocaine, methamphetamine, those sort of things. The treatment for TIA is the same as a stroke because it presents exactly like a stroke. So we're going to treat it the same way as a stroke, call a stroke alert, move them down the road, reassessing them every 5 minutes to see if their neurologic deficits have changed. Meningitis is an infection of the meninges. And the meninges are the three layers that cover the brain and spinal cord, the dura mater, the arachnoid membrane, and the pia mater. And with meningitis, it could be caused by a virus, a bacteria, or a fungi. And fungi are very difficult to treat and manage with medications, antifungals, those sort of things. But if it's viral or bacterial meningitis, neither of those you want to get. So, somebody with a high temp, particularly sudden in onset, that's to a point where they're calling 911, you need to take personal protective equipment. If not, put a mask on them, wear a mask yourself, along with gloves, that sort of stuff. Because if it's viral meningitis and you get it, there's no cure for that viral meningitis. They have to just treat the symptoms. Excuse me. And if it's bacterial meningitis, then they'd have to determine which antibiotic would work well. It can be caused by an enterovirus. It can be caused by a herpes virus. It can be caused by mumps. Children are often, it's an infection secondary to another bacterial infection that they have that spreads to the brain. And it can be the result of the direct entry of bacteria into the central nervous system from penetrating trauma. There are vaccines available for meningitis, for, certainly viral meningitis. There is a vaccine. It has a tendency to group itself with people who cohabitate closely with other people. So college students, military veterans living in billets, that sort of stuff. Meningitis has a tendency to increase in late winter and early spring. It presents like a flu, high fever, headache, non-blanching rash. They eventually develop petechiae and maybe in the very severe stages purpura, but they get this petechial rash. They also get what's called nuchal rigidity, or a stiff neck. They're unable to touch their chin to their chest. When you ask them to touch their chin to their chest, they're going to stretch the meninges of the spine. And if they have meningitis, an inflammation of the meninges, it's going to be very painful. So here's a picture of a brain that has meningitis, and you can see the redness and the irritation of the meninge, and in this case it'd be the pia mater that's fit tightly to the brain itself. Standard precautions, as I had mentioned, very important that you practice your use of your personal protective equipment. Supportive care, management of pain if they're having severe headaches, antipyretics if they've got a high temp, monitor them and be ready to treat for seizures with benzodiazepines should they start to seize. Make sure that they maintain a patent airway. If they've got a lot of secretions and their mental status is altered, you may have to provide suction. You want to give them oxygen based on your pulse oximeter, hook up a cardiac monitor, start an IV. If their mental status is altered, certainly check their blood glucose. And repeat your vitals and mental status assessment every 5 minutes. Encephalitis is a brain tissue infection where meningitis is an inflammation of the meninges. Encephalitis is an infection of the brain tissue itself. Again, like meningitis, it can be viral, it can be bacterial or parasitic. West Nile is an example of an encephalitis caused by mosquitoes. They present just like meningitis with flu-like fever and fatigue, sore throat, headache, nausea, vomiting, drowsiness. The light hurts their eyes and their mental status is altered. As the encephalitis progresses and more of the brain tissue becomes infected, it doesn't function properly, and so you'll get some nervous system dysfunction, much like you would a stroke. So some differential diagnosis associated with encephalitis include brain abscesses or tumors, hypoglycemia, meningitis, psychiatric disorders, status epilepticus, or subarachnoid hemorrhage. Those could all be mistaken for encephalitis. Your therapeutic interventions and the treatment is supportive with your personal protective equipment. Oxygen is necessary. Airway management is necessary. Establish an IV and transport. Shingles. Shingles are the result of the varicella zoster virus, which is chickenpox. The virus travels to sensory nerves deep within the body, and it lies dormant for years and years and years. But in some people, that virus is reactivated, particularly older in life. It can happen in younger people, but it's more common older in life. There is a vaccination for that, but you have to be over a certain age. I think you have to be over 55 or maybe even over 60 in order to receive the shingles vaccination, which lessens your chance of getting shingles. Oftentimes, shingles will follow a dermatome, and when they present particularly on one side of the body. This gentleman seems to have it on both sides, so he has very advanced stages, very serious shingles infection. Oftentimes they show up around your belt, they show up on one side of your back, again following a particular dermatome. And as you look at this gentleman here in the slide, you can see this rash, which you could imagine would be extremely painful, and it is. But more importantly, along the nerve root inside the body, the nerves look just like this. They're red, they're inflamed, they're swollen. So oftentimes patients with shingles will get severe burning and pain without the rash initially. And then later, as it erupts on the skin, you can see it, but it has been for some time going on in the body. So the patient's extremely sensitive. Pain develops along a unilateral dermatome. It progresses to a reddened rash, raised bumps, blisters filled with pus, and they eventually scab over. Scabs fall off and the rash disappears, and the pain can last 3 to 5 weeks. I knew a friend of mine who got shingles on the lower part of his back, and it was closer to 3 to 5 months before he saw any sort of relief from those shingles, using everything that they could throw at it. Therapeutic interventions include standard precautions. It is not contagious unless you're immunocompromised. And the reason it's not contagious is that most of us have it, because there are very few of us that have not had the chickenpox. You want to be supportive. Certainly if they're in a lot of discomfort or pain, you can give them medications to help with the pain. Poliomyelitis is a highly infectious viral disease. It's caused by direct fecal-oral contact and indirect contact with the saliva and feces. Can be found in contaminated water. It enters through the mouth, multiplies in the intestines, and spreads to the lymph nodes and the blood, and then attacks the motor neurons of the spinal cord and brainstem. So this is polio. Most people are asymptomatic, but you can have a fever, nausea, vomiting, fatigue, headache, neck stiffness, extremity pain. So it starts out, perhaps feeling like any sort of, I'm trying to think here, fever, nausea, vomiting, fatigue, headache, neck stiffness. So it starts out like an encephalitis or a meningitis. But with polio, paralysis can occur. Post-polio syndrome, 20 to 30 years later, patients develop excessive fatigue, progressive weakness, of the formerly paralyzed muscles. Pretty much here in the United States, we've wiped out polio as a result of aggressive vaccination programs. But one of the disadvantages of people coming into the country not properly vaccinated is that perhaps we would see this again. Your therapeutic interventions are supportive, ABCs, analgesics for pain, avoid narcotics. Polio patients, because of the weakness of their and fatigue of their muscles, giving them analgesics or narcotics, giving them narcotics may cause them to stop breathing. Alzheimer's disease is a degenerative nervous system disorder causing dementia. Now, delirium and dementia, we already talked about those being two different things. Delirium, there's typically a cause, a treatment. It's reversible, where dementia is a gradual degenerative nervous system disorder. And it's caused by clumps or bundles that grow onto and between neurons, choking the neurons and causing widespread cell death. The brain shrinks. It begins in the hippocampus and it spreads to the frontal and then temporal lobes of the cerebrum, affecting personality, motor function, causing hallucinations, those sort of things. In early stages, there's going to be slight memory lapses, issues with cognition, maybe some communication issues, maybe unable to perform some of the simple daily tasks. But in the late stages, the patient will have a complete loss of short and long-term memory, perhaps maybe bedridden, and maybe quite hostile, but not know that they are. Some differential diagnosis for Alzheimer's disease. Of course, Alzheimer's disease is one of those diseases that can only be truly diagnosed on autopsy. But Parkinson's disease may present like Alzheimer's. Stroke may present like Alzheimer's as well. The therapeutic interventions is to be supportive. Patients and family certainly need emotional support because it's very difficult to watch a loved one progress to the point where they now need assistance with daily chores. They need assistance in making, everyday decisions from how to dress, what to eat, where they are, who they are, those sort of things. Parkinson's disease is a brain degenerative disorder as well. It involves the extrapyramidal system, which is responsible for fine motor coordination and posture. It's usually the result of deficiency of dopamine in the cerebellum. It can be mistaken for Alzheimer's disease or stroke, and the therapeutic interventions for the treatment of Parkinson's disease in a pre-hospital environment is certainly supportive and monitor their ABCs is about all we can do for that. Amyotrophic lateral sclerosis, or ALS, which is also known as Lou Gehrig's disease. Certainly ALS, saw an increase in funding and certainly an increase in recognition of the disease itself with the bucket challenge. It is a degenerative disease of the motor spinal nerves. So over time, a person loses voluntary muscle control. Sensation and mental abilities are unaffected. But at some point, with loss of muscle control, the patient is unable to control the diaphragm and is unable to breathe and dies as a result of respiratory paralysis and death. It begins as a clumsiness or a weakness in perhaps in one hand and spreads throughout the body. Usually people diagnosed with ALS die within 5 years. The differential diagnosis might be a brain tumor, might be dementia, might be diabetic neuropathy. Diabetic neuropathy occurs in diabetics, particularly with high high blood sugar levels. the higher the blood sugar levels are. The constant high blood sugar levels destroy the nerves in the hands and the feet, and then begins to affect circulation as well. So initially it might be mistaken for ALS. And myasthenia gravis is another nerve muscle wasting disease. Therapeutic interventions is certainly patients with ALS may be on home ventilators, may have Foley catheters in, those sort of stuff. So making certain that their equipment's in good working order and working properly, and that they don't have some sort of urinary tract infection or some sort of central line infection. Pneumonia in these patients certainly would cause a respiratory failure. With the muscle weakness, aspiration is always an issue. If a patient has ALS, certainly checking for a DNR order would be appropriate. Multiple sclerosis is an autoimmune disorder. An autoimmune disorder is when the immune system attacks a part of the body. They believe, as an example, that multiple sclerosis, where the myelin sheath on the nerves is under attack and causes dysfunction of the nervous system. Diabetes, they believe, is an autoimmune disorder where the immune system attacks the islet of Langerhans and the beta cells in the pancreas, making it unable to secrete insulin. Some history and physical findings with multiple sclerosis: vision loss, fine motor control loss, extremity pain, facial pain, paralysis, hearing loss, and vertigo. Some differential diagnosis for MS might be brain tumor, certainly could be brain bleed. Therapeutic interventions are supportive, and because it is a neuromuscular wasting disease, you might have to manage the airway. Guillain-Barré syndrome is another autoimmune disorder. It attacks the peripheral nervous system. It's usually the result of as an insult to the immune system. Causes weakness and tingling in the legs. Muscle strength in the extremity weakens. Later the patient becomes paralyzed. And because they are paralyzed, they end up on a mechanical ventilator. Guillain-Barré's doesn't eventually go away. The patient eventually dies as a result of this neuromuscular wasting disease. Some differential diagnosis for Guillain-Barré include encephalitis, iron poisoning, hyperkalemia, hypermagnesemia, hypokalemia, meningitis, myasthenia gravis, which is another muscle wasting disease, organophosphate poisoning, polio, snake envenomation, and spinal cord injury. Some therapeutic interventions: if they're having trouble with their airway or breathing or clearing their secretions, certainly we need to open their airway and breathe for them at an adequate rate and depth, establish a pulse oximetry, a cardiac monitor, some oxygen. Patients may need to require intubation, and if they are bradycardic, then administer atropine. Myasthenia gravis, an autoimmune disorder, causes muscle weakness, fatigue. The lymphocytes attack the acetylcholine receptors on the voluntary skeletal muscles and blocks those neurotransmitters. The myasthenia gravis is related to the thymus portion of the brain. With myasthenia gravis, they may start out in the morning with good muscle strength, full muscle strength, everything's good to go, but as the day wears on, they get weaker and weaker and weaker, and have to rest then in order to recharge. Myasthenia gravis may affect the muscles of the eyes, the eyelid, the facial expressions, the shadowing, ptosis, and respiratory muscle weakness. Some differential diagnosis: of course, ALS, aspirate pneumonia, brain tumor. Brown-Séquard syndrome is a spinal cord injury. Chronic obstructive pulmonary disease could be a differential. Guillain-Barré's, heart failure, hypercalcemia, hypermagnesemia, hypokalemia, hypothyroidism, ischemic stroke, secondary spinal cord injury. All these things could be potential differentials for a sudden onset of muscle weakness. Therapeutic interventions, airway, suction, pulse ox, cardiac monitor, oxygen and ventilation, tracheal intubation if necessary, establish an IV, which can be done en route and transport. Huntington's disease is another degenerative neurologic condition. The neurons within the brain undergo a genetically programmed death. The brain atrophies or shrinks. In patients with Huntington's disease, you see a radical personality change, a loss of intellectual function, and they may be physically debilitated. Some history and physical findings with Huntington's: irritability, moodiness, depression, cognitive dysfunction, progressive dementia, movement disorders, and psychotic symptoms. Some differentials for Huntington's. You might think that a person with Huntington's would have, alcoholism or Alzheimer's or be bipolar or Parkinson's. Therapeutic interventions for Huntington's disease is to provide supportive care. Spinal cord compression. We often think of severed spinal cords as a result of trauma, but certainly the spinal cord, which occupies arguably anywhere from 90 to 80% of the spinal canal, if that swells, or if you get a ruptured disc, or a compression fracture of the vertebrae, or if the vertebrae pop out of line, penetrating objects to the vertebrae, etc. These things will all cause swelling, and the swelling will decrease blood supply to the cord, and that will lead to neuronal death and eventually spinal shock. If a lesion is high in the cervical spine, then of course the respirations will be compromised. If it's real high, then there'll be no breathing at all. If it's a little lower, like C 5, 6, 7, then you'll still have the ability to use the diaphragm. Full neurologic examination, perhaps spinal cord immobilization, and then if they aren't breathing on their own, you may have to provide ventilations, establish an IV, may need fluids to keep up blood pressure. Autonomic dysreflexia is a life-threatening spinal injury. It's a spinal cord injury above T5 or T6. The brain is unable to communicate with the sympathetic nervous system, so the patient develops hypertension with their bradycardia, which could potentially be life-threatening. With autonomic dysreflexia, we want to have the patient sit upright. It's often caused by distended bladder in the elderly or impacted bowels. So check your catheter for kinks, twists, and flush to make sure and clear any blockages. If you've got a Foley catheter in place, certainly making sure that it's flowing well and it's not occluded. If you don't have a catheter in place, then in this particular patient, you'd want to put in a Foley catheter. If they are impacted, you would need to remove those impacted feces with a gloved hand and then transport immediately if there is no change in blood pressure. Hydrocephalus, hydro of course referring to liquid, cephalus referring to head. This is where they make an excessive amount of cerebral spinal fluid. and this may be a congenital disorder, or it also can be caused by an illness or an injury of the central nervous system. But what happens is, because of this excessive amount of cerebrospinal fluid, they're not able to remove it, and the water, or the CSF, collects inside the skull, causing the intracranial pressure to rise, which could lead to herniation syndrome and death. So they have to put shunts in the head itself to allow that extra cerebrospinal fluid to leave the inside of the skull. Spina bifida, this is when the meninges are herniated through the spine and they're on the outside of the skin. It's a result of incorrect spinal development. And there are two types, the occulta and the meningeocele. With the meningeocele, the spinal cord and all that are within the meninges, laying outside the skin, rather than inside the spinal canal. Latex allergies are really common in people with spina bifida, only because of the number of surgical procedures. They're also taught to control bowel and bladder function by blowing up balloons, which often are latex, so they're exposed to latex quite often, and as a result, some may develop latex allergies. So be cautious, if you have any latex equipment that you might use around a patient with spina bifida. It is certainly a major disability. Many of these patients born with spina bifida ever walk. Their lifespan is usually short. It usually requires multiple surgeries to correct it, and it never is completely sealed or corrected. Other disorders include muscular dystrophy, which is a progressive muscle degeneration. It's due to the Duchenne sex-linked gene. It's more common in males. You'll see it in what they call grower's sign, and this is really interesting in children who have a tendency to walk on their toes. They keep their heels up off the ground as they learn to walk, and they don't like to put their heels flat on the ground. They also may have malformed cardiac muscle, so their heart may not work well as a pump either. Some other disorders include dystonic reactions, and this is abnormal muscle tone. Can occur in the head, the neck, and the tongue. It's also a side effect of certain antipsychotic drugs, particularly like MAO inhibitors, can cause dystonic jerks or tics. When it does occur as a result of an overdose of an antipsychotic drug, the dystonic reactions can be reversed with 25 to 50 milligrams of diphenhydramine or Benadryl, IV or IM. Another disorder is trigeminal neuralgia, and trigeminal referring to the trigeminal nerve, which is a cranial nerve, the same nerve that when pinched will cause a facial paralysis with Bell's palsy. So it's the trigeminal neuralgia is a very sharp, violent pain in the face. It's a result of trigeminal nerve irritation. Again, the trigeminal nerve is a cranial nerve, and for some reason, anti-epileptic medications help ease the symptoms of this. Bell's palsy, again, paralysis of the facial nerve, may present with pain behind the ears, altered sense of light, altered sense of hearing. There may be drooling, eye tearing, believed to be caused by herpes simplex, the same thing that causes cold sores. There is no cure. However, people that develop Bell's palsy are often put on prednisone or a steroid to help reduce the inflammation, and then antiviral agents. And the side effects that you see with Bell's palsy may resolve within 3 months to 1 year of taking those medications. It's interesting that, in addition to the pain behind the ears and the altered sense of sight or hearing or drooling or eye tearing, is that when the facial nerve becomes paralyzed, they're unable to blink as well. So their eyes tear mainly as a result of their inability to blink, and the eyes dry out, and the body's response is to tear. So it's the wrinkles in the forehead go away. They can't blink that particular eye. They have trouble working their tongue. Their speech is slurred. Eating is a challenge. Taking a shower is a challenge because they can't close that eye. And it can be quite the experience for up to 3 months or a year. All right, so with that, we have finished up Chapter 21, the neuro section, and I will be talking to you soon. I think next we go into endocrine, if I'm not mistaken, but we'll talk to you soon.